Okay, so we have a kind of a mini pharmacology lecture for the aortic stenosis case. One of the outcomes of aortic stenosis is heart failure, and it's specifically heart failure that's characterized by basically a preserved left ventricular ejection fraction, meaning a normal left ventricular ejection fraction. This used to be called diastolic heart failure, and this is how I learned it back in the day. So if you hear diastolic heart failure come out during this lecture, this is really what I'm referring to. But what is it? It's that basically, in contrast to systolic heart failure, which is usually caused by previous heart attack, ischemia, and so forth. Diastolic heart failure, or heart failure with preserved ejection fraction, these patients tend to have hypertension, sometimes are elderly, female, obese, and have comorbid conditions, atrial fibrillation, diabetes, or in this case, aortic stenosis. Here's the prevalency and frequency rates for the population. And, excuse me, just to remind you that this term diastolic heart failure, it's an older term. It's still somewhat relevant, which is why I included it in this lecture. It's the term that's used in the STEP exam. It's still the term used in textbooks. However, it's not really clinically relevant. Kind of the newer modern term is this heart failure with preserved ejection fraction, or HFpEF, which doesn't roll off the tongue. So either of these are essentially the same thing. I don't care what you call them as long as you understand what they are. If you hear me call it diastolic heart failure during this lecture, this is what I'm referring to. All right. So what are the drugs that are used in diastolic heart failure, or HFpEF? Yeah, that doesn't roll off the tongue. Basically, not many. Very few of these drugs have demonstrated, major beneficial effects in terms of survivability and hospitalizations and so forth. And so I just wanted to touch on a few of the drug classes that at least have the potential to be used for this type of heart failure. And I wanted to tie it into the George Papadakis case. All right, and so here's kind of a targeted approach. This is from a textbook on how to treat diastolic heart failure. And so some of the physiological targets are listed here, and then the rationale for using the specific agent or agents to treat it. Excuse me. And so the first group of drugs we want to revisit are the ACE inhibitors. And so the rationale, at least for the Papadakis case, is that we're going to treat his underlying hypertension, which is really kind of the driving force behind his heart failure. Okay, and this is a great slide. I stole this from Wikipedia, and although it is from Wikipedia, it is actually quite good. One of the mastery questions alludes to, what's the rationale for treating this patient with an ACE inhibitor in the context of heart failure? And this is really the answer. So all of these are physiologic outcomes to angiotensin II, and this is why inhibiting the production of angiotensin II is a viable target. And so all these little green pluses are the physiologic outcomes to what angiotensin II does. And so then if you inhibit it, you reduce these physiologic effects systemically. And so this is why an ACE inhibitor is at least probably a smart choice for this patient, although from a evidence-based medicine perspective, they don't particularly do that much better if they were off of it. Which I know kind of is counterintuitive, but in terms of survivability and so forth, those are some of the outcomes to those studies. Understand that there's lots of drugs that can target the renin-angiotensin-aldosterone system. For diastolic heart failure, or at least heart failure with preserved ejection fraction caused by aortic stenosis, really the only one that might have any type of clinical benefit are the ACE inhibitors. The other drugs listed here have yet to show any type of benefit in this particular patient population. Okay, and just to review, these are all your ACE inhibitors. They all end with pril. As of right now, they're essentially equally efficacious, meaning you can pick any one of these and you'll get a similar type of outcome. That same logic doesn't really hold true with beta blockers, which you've seen. We've talked about specific beta blockers for specific indications. We've talked about maybe specific statins for specific LDL lowering intensities, but for all practical purposes, as long as you know that these are all ACE inhibitors and you can use them essentially interchangeably, that's probably the main point here. Excuse me. There's two main side effects to ACEs that you have to be aware of. The first is this dry cough, okay, and the second is angioedema, which looks like this. And so really this is it's a vascular type of hypersensitivity reaction, and the outcome is really swollen lips, swollen eyes. In some cases, this patient, her eyes are actually swollen shut, and then there might be some difficulty breathing because some of the airways can get swollen as well. And so, if the patient presents with angioedema due to an ACE inhibitor, they have to come off of it. You can treat with some other drugs. Definitely, something like Benadryl will work to reduce some of the swelling. But there's other drugs that we'll talk about later on how to actually treat this when it does come about. If they do get angioedema, they have to be off the ACE inhibitor and put on something else, like an ARB. In terms of ACE inhibitors and when you avoid them, I wanted to draw two particular points to patients that have underlying renal dysfunction and patients that have hyperkalemia, so too much potassium. These two particular subgroups of patients, aside from pregnant women, should avoid ACE inhibitors, and that's really why, if you look at the Papadakis case, we looked at serum creatinine as a marker for renal activity or renal function, and we looked at serum potassium just to kind of get like a baseline before putting him on an ACE inhibitor. And so if he had renal dysfunction or if he had hyperkalemia or both, you would probably think twice about starting Mr. Papadakis on one of those ACE inhibitors. Okay. Excuse me. Sorry. Speaking of cough, that's what I have. The diuretics, the other drug that he was prescribed was furosemide. And so the rationale for giving him furosemide was to really kind of reduce the volume overload that accompanied the ankle swelling and the short of breath with walking. And so I wanted to draw your attention to this particular drug class because he's probably not going to be on it for very long. They were probably just going to put him on furosemide for maybe a week or so, just to kind of remove the majority of that volume overload. And we'll talk about why that is so in a couple of minutes. Here's the kind of the background for the mechanism of how loop diuretics work. Don't get hung up too much on the mechanism because we haven't done renal physiology yet, but understand that what we're going to do is we're going to remove water from the system. Okay, we're going to force diuresis, so the patient's going to urinate more frequently. And remember that anytime water leaves, sodium is going to leave with it. So anytime sodium leaves and water leaves, we're going to really do two things. We're going to reduce end diastolic volume, which is preload, and we'll increase very slightly, stroke volume and cardiac output. So this is kind of okay. It's not really a molecular or a physiologic target because for all practical purposes, his cardiac output is essentially normal. The one thing that does kind of worry me in terms of furosemide, and this is kind of the teaching point here, is that if you reduce end diastolic volume, if you reduce preload, that's really going to hamper his cardiac output because the aortic stenosis aspect of his disease is going to reduce afterload. If you reduce afterload and you reduce preload, you can actually shortchange the patient, so to speak, and that preserved ejection fraction can become unpreserved, meaning become less than normal, and you might mess up with some of his cardiac output. So loop diuretics in the context of diastolic heart failure are kind of contraindicated, at least for kind of long-term use. It makes sense in this particular case for this patient because he does have volume overload, and this short implementation of furosemide is really going to reduce that volume overload and kind of get him back to normal. Okay, and of course the major side effect to loops is going to be dehydration, and so just like ACE inhibitors can cause hyperkalemia, too much potassium, loop diuretics can deplete it and cause hypokalemia, too little potassium. And of course, you can see metabolic conditions, which we'll talk about during the renal aspect of this curriculum. And so, other considerations to think about in terms of heart failure with aortic stenosis is this reduction in preload might be problematic in the long run. And so that's really the justification for really, not keeping him on, him meaning George Papadakis, not keeping him on, long-term furosemide, just to kind of really get some of that volume overload and get a handle on this disease. Okay. Contraindications to loops are listed here. We've talked about this earlier. The other group of drugs that you might encounter in terms of step material that are listed in terms of diastolic heart failure are beta blockers. Remember, beta blockers do a whole series of inhibitory type of effects in terms of heart rate, contractility, conduction velocity, and so forth, all of which are listed here. Okay, but in terms of the beta blockers that are specifically used for diastolic heart failure, or heart failure with preserved ejection fraction, the only one that we're really looking at is nebivolol. This is because this particular beta blocker has been shown to be somewhat effective in clinical trials for these particular patients, and that clinical trial is listed here. It's the seniors trial. Nebivolol is kind of a unique beta blocker in that it's a beta-1 antagonist, but it also has some vasodilatory properties as well, something that centers around the nitric oxide production pathway at the endothelium. We don't exactly know how that works, but we know that it happens with nebivolol. And of course, some of the side effects to beta blockers are listed here. Of course, the main one's going to be bradycardia and low blood pressure. Excuse me. Other patients talk about maybe having depression or weird dreams. These would be beta blockers that cross the blood-brain barrier. Some will cause GI distress or abdominal discomfort, although this is, relatively uncommon. Beta blockers do have some role in sexual dysfunctions. And of course, beta blockers have the unique ability to elevate lipids. And so you might worry that this would be kind of a major contraindication to any heart patient. But what do we always give heart patients, no matter what? A statin. So this slight elevation in lipids is going to be basically destroyed by the statin that's going to be co-administered, regardless of pretty much any cardiac pathology. Of course, these are the conditions where you would avoid beta blockers, and we'll talk about these as the curriculum wears on. So just kind of to summarize, excuse me, just to kind of summarize, the best treatment for Mr. Papadakis is going to probably be a new aortic valve, because his current aortic valve is stenotic. These drugs are basically going to be short-term kind of band-aid solutions to major problems. So that's one of the things that I just kind of wanted to drive home. None of these drugs work, magnificently, but they all will kind of reduce some of the symptoms and at least buy him some time to become stabilized, more comfortable, and hopefully strong enough to basically have this surgery. And that's pretty much it. There's very few drugs to treat diastolic heart failure. The best way to treat diastolic heart failure is to prevent it. And the way to prevent it is to treat the comorbid type of diseases that can produce diastolic heart failure. So hypertension, atrial fibrillation, aortic stenosis, and so forth. Okay? So that's it for this particular lecture. And if you have any questions, please email me. Thank you.